Should I just share my screen first, Prakash?
Uh, Perhaps when your session starts, Varsha.
Oh, sure. Sorry. Yeah.
So, good evening, friends. Welcome to the fifth episode of the dialogue series on primary healthcare, an initiative by the Center for Primary Healthcare at BHS and the Center for Healthcare at IM Udaipur. BHS is incubating the Center for Primary Healthcare with a vision of a place that makes freely available knowledge, tools, training, and technology to design, implement, and evaluate primary healthcare services for the marginalized. Its mission is to conduct relevant research, synthesize evidence, and develop capacities of individuals and institutions to design and implement responsive primary healthcare for marginalized populations. The Center for Healthcare at IIM Udaipur focuses on healthcare related research from a management perspective. It serves as a platform for researchers, practitioners, policymakers, and other stakeholders to collaborate and create evidence based impact. Currently, the center prioritizes research in primary healthcare. The dialogue series on primary healthcare aims to highlight key issues in the field, bringing together researchers and practitioners to discuss evidence based insights. The series invites speakers who have deep experience of practicing, researching, or policy making on primary healthcare and its different aspects. They share evidence and insights from their own research and practice and discuss their implications on the larger primary healthcare ecosystem in India. So welcome again to today's episode. I invite Dr. Pavitra Mohan, the co-moderator for today's session, to introduce today's episode and also the panelists for today.
Thank you, Prakash. Welcome everyone again. Uh, you know, as Prakash said, that we've been conducting these dialogue series on primary healthcare, focusing on different domains of primary healthcare, from human resources to financing to technology and now to diagnostics. And diagnostics are personally for me and for BHS a very important area of work, because I think in primary healthcare, the quality of primary healthcare, what it can do, the scope of it, depends a lot on what you can do by way of diagnostics at that level of services, and which is fraught with a lot of difficulties. Unlike in hospitals where you have electricity, uninterrupted electricity, IT systems, lab technicians, microbiologists, molecular biologists, and all the paraphernalia. In primary health setting, they're very limited infrastructure. There may not be any people specialized to conduct diagnostics. There may be interrupted electricity. There is often IT systems that are erratic because of poor connectivity. And in absence of all that, you are expected to deliver a whole range of services, from newborns to elderly, from communicable to non-communicable. And therefore, the challenge becomes huge. And the need for reliable, easy to use, hardy technology to diagnose becomes extremely critical. It makes all the difference between referring a person 100 kilometers away versus being able to manage the person right there where the person needs it the most and is unable to travel. So the whole cost, the delays in diagnosing, the cost of care, the severity of disease. I'll give you one example from my something that I always think about is that when I was doing my residency in pediatrics, it would take 2 days to even diagnose malaria in a tertiary hospital, because if the person comes in the evening, you take a sample, the technician would come next day, etc. And often the person who comes with malaria would be that of cerebral malaria, extremely moribund, because he could not be diagnosed early enough. And now in our remote primary healthcare clinics, having a rapid diagnostic kit right there empowers the nurses being there to diagnose it within 15 to 20 minutes and then treat. Often people are treated at 1/100th of the cost it would take to reach a hospital. And also the outcomes are so much better because the treatment and diagnosis has happened at the first presence to a clinic. So there are huge value, but unfortunately most diagnostics that are developed, there are a lot of technology that has developed. Most of it is suitable for hospitals and for places with good infrastructure, with a lot of human resources to run the machines, etc. While in primary health care settings, often the diagnostics are still limited. Sometimes they are unreliable, and oftentimes there is lack of information on which diagnostics to procure or to deploy and how to use them. So these huge gaps kind of prompted us to have a specified consultation focusing on diagnostics in primary healthcare. So it's not any diagnostics; it's diagnostics for primary healthcare. And we could not have better panelists than Dr. Mikashmi Kohli and Dr. Varsha Shridhar. I have actually, by the way, never moderated two PhDs, so I'm a bit nervous right now. So very distinguished analysts who have spent a lot of time, energy, resources, and their professional competence to find out, understand, and to find out solutions for diagnostics in primary healthcare. I'll begin with introducing Dr. Mikashmi. She is a public health expert with almost a decade of experience in TB diagnostics and evidence-based medicine. She has led several projects focused on the accuracy, availability, and accessibility of TB diagnostics, particularly within primary healthcare setting, and that's why she's here today. She also serves on WHO expert committee for pre-qualification of TB diagnostic tools, and she has also been on the Lancet Commission on Diagnostics, where she had focused on care cascades as well as cost modeling to support diagnostic implementation strategies. Dr. Kohli holds a PhD in molecular medicine from AIIMS New Delhi and a postdoc fellowship at McGill University with the PI Global TB Group. The reason she's here, as I said, has been because she has studied and tried to find out solutions for diagnostics in primary healthcare in low resource settings, and has also conducted several studies on diagnostics in primary healthcare in India, including a landscape analysis of diagnostics in primary health centers and TB diagnostics. So welcome, Kohli. Our second panelist is Dr. Varsha Shridhar, who, besides being a friend, holds a PhD in molecular virology and microbiology from University of Pittsburgh and a postdoc fellowship in maternal and child health from Women's Research Institute. She is a co-founder of Molecular Solutions for Health, which began as a diagnostic and device development company and now operates in clinical infectious diseases, primary care diagnostics, and environmental surveillance. She recently conducted a landscape of primary care diagnostics in India, has also been engaged in solutions for TB diagnostics in rural underserved locations, and has been also working with public systems in a large implementation research trial to find out diagnostic solutions for primary healthcare settings in rural India. Welcome, Varsha. So to begin with, I would request Dr. Mikashmi to start with her presentation. The way, as you know, these dialogues are designed is to begin with the presentation, some either on single research study or on synthesis of research findings, and then discussing more its practice implications. So over to you, Mikashmi.
Thank you, Dr. Pavitra, and thank you for also giving me this platform to discuss the work. I think amidst a lot of people who are passionate about diagnostics, and especially diagnostics in primary healthcare, this has been my passion for so long, and is still continuing. So I'm glad to be amidst everybody who is interested and passionate about the same work. I'm just going to share my screen and just give me a thumbs up if you can see that. Perfect. Okay. So I'm going to talk about diagnostics and diagnostics specifically in primary healthcare. So how I structured my talk is mostly, we all know that there is a problem. We all know that there is not proper diagnostics available or even accessible to people. We know that there is a problem. So I'm going to talk about the evidence where it says what the problem is. And I've put together pieces of work that I have done or I have been engaged in to talk about the evidence on what the problem is. But I am more of an optimist. So I also want to talk about some solutions and not leave this platform with just the problems. So As Dr. Pavitra had mentioned, so I'd worked on the Lancet Commission on Diagnostics, which came out in 2021. This was the first ever paper that actually mentioned what is the problem with diagnostics, where we are at. It was a very evidence-based paper that we wrote, and there was this whole commission with people across the globe who worked on this. There were a couple of key messages. There were 7 key messages, and there were 10 recommendations that we stated out of this paper. The 7 key messages are here, but one of the biggest messages was that about half of the global population has little to no access to diagnostics. Now, this is about the global population. But when we did this modeling just for low and middle income countries, it came to about 70% or over 70%. We all actually know that diagnostics are underfunded, and the primary health care, which is actually where people go and seek care first, is something where it's the most underserved and suboptimal availability and accessibility of diagnostics is available there. Now, COVID-19 was a problem that we all saw together, but it was also a boom for diagnostics where there were a lot of new innovations that were coming up during the pandemic, and people learned that we need to be resilient within our own countries first, because nobody's going to come save us from the global north, and nobody's going to help come save us from the pandemic. Everybody's going to work at their own homes first. Another really interesting message that came out of the Lancet Commission was we looked at only 6 conditions first. And we said that only for these 6 conditions, if we increase the availability of diagnostics, because there was a whole diagnostic care cascade that we did, if we increase the diagnostic availability, we were able to save 1.1 million deaths only from those 6 conditions. And then there was a cost modeling that we did where because we get a lot of questions from majorly investment bankers asking us, why do I need to invest in diagnostics? Maybe I should just invest in vaccines or drugs. But when we did this cost modeling to actually answer those World Bank questions or investment bankers questions, we did see that every dollar that is invested returns multiple dollars in return. Just for a disease like TB, $1 invested was equivalent to $40 in return. Then we did a little bit of a study to understand what is the availability of diagnostics at primary healthcare. So this is what came out. We looked at the data from 2007 to 2018 for 9 LMICs and 1 upper middle income country as well. It was something that was a little bit surprising and shocking that, well, something like HIV, malaria, urine dipstick, or something like blood glucose should actually be available at 100%. And especially for a blood glucose like test, which is easy, doesn't require an invasive procedure, a glucometer and test strips are the only things that you need. The availability was just around 30%. And this is for 9 LMIC countries. And the availability and the reason why HIV malaria was much better than the other test is just because of the vertical programs, and just how we are structured in our national programs is concentrate and invest on the siloed vertical programs rather than the whole health system. This was another thing where we saw, and it was very interesting, that when we looked at Malawi for HIV diagnostics, most of this country actually was in the blue, which is around more than 65-70% or 80% was HIV diagnostics were available in the country. Whereas when you look at a glucose test, this was the same story even in Malawi. It is less than 20% in the entire country. And the reason is just because we don't think of a person as a person, we think of a person as a particular disease, and we think this is a vertical program. I should invest in a vertical program rather than investing in the system itself. And this was a study that I did that actually led in India, where this was the same question that I had, like, what is the availability of diagnostics across India? The story was very similar. We had I reviewed this in three different states, one in UP, one in South, and one in Central India in Wardha. And the interesting part was that mostly in up north, as we also kind of expect, the availability of diagnostics was suboptimal and probably not even present. In the southern part of India, we did see a lot of these tests being available, but again, the issue was that they were focusing more on the vertical programs. They needed to reply back to the national programs, and they were keeping a record of it. Interestingly, Vardha had all the tests that they needed to get done at a primary healthcare level, and the reason was that the state had already invested in a PPP program, in a public-private partnership program. And that is why they said, even if in-house I don't have a test, I don't have a glucometer strip available on site, I can at least send the sample or the person to a private lab to get tested. And there was accountability of that. And that was something of a positive outlier that we saw. And it is not just India. It was something that we saw in Sierra Leone. It was very similar situation in Peru. It was similar situation in Nigeria, in South Africa, and this is across the globe. But again, as I said, these are problems. The question that I started asking after doing these landscape studies and understanding that there is a problem, what do we do about it? And talking about some of the solutions, we started looking at the question. I think somebody in the beginning said, what diagnostics should actually be available at a primary healthcare? Because people are really asking us this question. I can't put everything at a primary healthcare level. It's just wastage of my resources and money. And that's absolutely correct. So we tried starting to understand, let's look at the disease burden. Where is it that we need to put in an effort at a primary healthcare level? And there is a systematic review. I think I forgot to add that. We looked at what is the primary reason why a person would go to a primary healthcare level. It would be fever, it would be cough, but what are the diseases that people actually come up with? And I highly recommend reading that systematic review as well. So this is a report that we tried to kind of do as similar as something that McKinsey did a couple of years ago, where what we were trying to see is not just now, but looking into 2040, what are the diseases that are gonna be impacting the global population? So we saw that there are a lot of infectious diseases that will obviously, like HIV, TB, NTDs and other respiratory infections, etc., that will come up, that has this likelihood of getting impacted at any spectrum of the age. But then there are these NCDs, cardiovascular diseases, other non-communicable diseases. India is now being called as the diabetic capital of the world. And that is not news to us. We actually saw this coming a couple of years ago, and looking at the trend, it's probably going to be more cardiovascular diseases and cancers that people are going to die of than infectious diseases. And what do we need at the primary healthcare for something like that is probably a portable ultrasound, probably a portable chest x-ray for if we talk about imaging, but just a simple glucometer test. Not difficult to have, but really good, but really helpful as well, right? And these are things that we tried understanding. Now, what are the recommendations that we could come up with is that maternal care, neonatal care, the NTDs and malarias, the CVDs and the diabetes, mental health, all of these are conditions that people should really start focusing on. There are diagnostic tests that people don't even know exist for some of these conditions. There is another study that we did where the question that we asked was, for an antenatal care for a pregnant woman, how many visits will a pregnant woman make at a primary healthcare center? According to the global policy, it at least like there should be 4 visits that should be made. How many were actually made? One or probably none. That was the average that we looked at. And these are some of the things like anemia or gestational diabetes. They can be curbed when people are being taken care of at a primary healthcare level, but we certainly don't think about it. So the first one of the solutions was, let's look at the disease trends and then let's see what diagnostics do we need. And this was a similar trend that we saw, okay, looking at 2019, what the disease burden was, and then looking at 2040, we are seeing the same trend that it will majorly be non-communicable diseases where we will need to start putting our focus on. Then what diagnostics are needed? It is not just a particular country, but also WHO. After 4 decades of an essential medicine list, a diagnostic list was created. So it took them 40 years to realize that diagnostics is important, we should think about it. So the first EDL was published in 2018 by the WHO. And since then, it has been revised and reviewed every single year. We are now in the year of the fifth EDL, and it will be coming out very soon as well. But it's not just WHO that says, let's put an EDL and that's it. It's countries who need to then start taking an action about it. And that is where a national essential diagnostics list come into play. This is an infographic from a Lancet update paper that has just been published on 25th of May. So just 5 days ago, it was published. I also recommend reading this paper. What this infographic actually is telling you is how many countries have an NEDL, how many are in the process of developing an NEDL, and even if there is no national essential diagnostics list, they probably have a document that says there should be a diagnostic. So this was a very informative infographic that I worked on. But I do need to say that India was the first country that developed its first national essential diagnostics list. And from that one country that developed that NEDL, we now have 13 countries that are in process of coming up with one or just about to publish another NEDL. So we are seeing a lot of progress. And why is that important? It is important because there was a time where medicines were not available and people didn't know which medicines should I be putting in my hospital, which medicines should I be putting in my district hospital or a tertiary care hospital or a primary healthcare hospital. But after the adoption of essential medicine list, these medicines are available and they know which medicines should be reimbursed, which medicines does government need to procure to put in these positions. And this is more of an advocacy document, but also to say that diagnostics are important and they need to be there and people shouldn't be paying out of pocket for that. Now, what are the implementation strategies? So you can say that this is a document, look at it, diagnostics should be made available. But what are the implementation strategies? How do we optimize it? One really successful example was looking at the public-private partnership. India, we all know, has a really huge private sector. Why not leverage that? Actually, some states have already started doing that and they started looking at how to leverage that piece. I'll just showcase a study that we did in India to understand which public-private partnership model would work best. And many states in India have different models that they work with. Then there is something called as a diagnostic network optimization. So you have the test you in one place, but probably a human resource available at another site, or vice versa. Doesn't really help, right? But then, and you have a very fancy machine in one primary healthcare setting, but the population that it is catering to is a very small population versus another setting where you can actually go and cater to a larger population. So what diagnostic network optimization really does is it looks at an entire population. It looks at the resources that you have, the human resources. It looks at the logistics, the roads, the transportation, the disease burden, and the diagnostic technology that it is available. And it provides you with some modeling aspect on where is it best placed to have the technology. And if the technology cannot be moved, can we have more optimized sample referral systems that would help benefit people? So this is what DNO does. In India, we have a lot many projects that are actually looking at DNOs to try and optimize this diagnostic utilization. Then we have some, and then obviously rather than making people move, why not bring diagnostics to people? So we are working on new innovative point of care devices that can actually be taken into community, or even something like a self-test. At the end of the COVID pandemic, everybody was able to take a tongue swab and do a test for themselves. And that is something that we're aspiring for. Capacity building, definitely it is something that is important. We need to not just look at the technologies, but also at people who will be doing these tests. And then something telemedicine. Everybody in India or even in other countries have access to internet. So everybody can actually get access to these telemedicine platforms, and that would help increase the accessibility and affordability of getting tested and getting a clinical opinion. So quickly on the types of different models that we looked at, the PPP model, this is another work that we did with Niti Aayog in India. Was there are three major models that India is working with right now. There is an integrated lab network system that has at least been adopted with Maharashtra and Madhya Pradesh and Himachal Pradesh. There is an integrated laboratory network only at the secondary and the tertiary level, where majorly people are being referred to these centers then. And then there is a rental reagent model where um, and these are sort of the models where you're expecting that the entire management of the lab is happening through government, through different reagents that are being procured for the primary healthcare settings, primary healthcare labs. A quick observation that we saw, the question that we asked was, in different states, there are different PPP models. Does it really work? Let's look at it in the quantitative mechanism. So we looked at these different states in India. So Maharashtra, Odisha, Jharkhand, HP, MP, and UP, and just the percentage change in the test to patient ratio that changed was amazing. I have no words how to describe that. But just a 152% change or a 93% change or a 400% change in just how many people were actually able to get a test just because the facility was available, just because either people could go get tested or their samples were getting referred and they actually had the access to getting tested. Point of care devices, I think that this is a well-known idea, and I do want to bring some quick examples here. So again, as I said, rather than making people move, it's important to bring diagnostics to them. This is a huge pipeline of tests that we are looking at. So there are tests that are more like centralized to be put in a tertiary care hospital, but what I want to focus on is something like this. These are small iPhone size, your mobile size devices. They can actually, they're handheld. You can take them anywhere, do not require electricity. And what we are trying to work on them is work with specimens that are easy to collect, like a tongue swab. So something that is going to happen in November this year, WHO is going to review evidence on can we detect TB using tongue swabs. And that's like a game changer, right? Like you don't need to go and cough into a sputum cup and even if there are so many people who cannot even produce sputum, children cannot produce sputum easily. So can you take a tongue swab and see that you have TB or not? And the technology that we are looking at is literally this small. And more than the size of the technology, it's also the ease of using this technology. You do not really need a lab technician all the time. A community worker, the ASHA workers that we have, or even a caregiver at home can actually do this test very easily. There are a lot of companies in India who are also developing these tests, and ICMR is validating some of these right now. And then, as I said, it's not just the sputum, it's also something about tongue swabs, it's about urine specimens, and also breath condensates. So, like during COVID, we were wearing these masks for the entire day. So, what people are now working on is if you sit there for 15 minutes and breathe into that mask, can we still take a breath condensate and try to see if you have TB or not? And that is also looking very promising right now. Chest x-rays, heavy machines. We always needed a big building to put this chest x-ray machine. But now we are working with something like this, which is a portable chest X-ray. You can take it wherever you want. It fits in your backpack and then you're off and you can get a chest X-ray. And not just chest X-rays. You need a radiologist to read these chest X-rays, right? But this is where AI is paving the path, where we have a lot many software that are coming out who can actually read these chest X-rays and tell you, do you have TB? Do you have silicosis? Do you have pneumonia? Do you have something like COVID? What is it exactly that is causing that problem in your lungs? And yeah, I just want to stop, pause here, and take any questions that you have. Yeah, thank you everyone for your attention and listening to me.
You can stop sharing. Thank you, Mikashmi. That was really wonderful. I think many ideas, and also, as you said, solutions to, or possibilities, I would say, because while there are solutions, they are still far from reach, but there is a movement and there are possibilities of making these tools accessible to the remotest of population. I love that picture of the X-ray being done in Himalayas or wherever, or Aravallis. And we burnt our fingers trying to set up an X-ray with with what used to be called a portable machine, which weighed 150 kilograms, and they needed stabilized power supply, and then it kind of blew up because the power supply is very erratic in the areas we work in. And then we had to do some jugaad to have salt uh, uh, in the ground where to earth the machines, etc.
Yeah.
And till we discovered one such really a portable one. But the point that the journey has been fairly recent from what you said, the first essential diagnostic list. Of course, it's not. There have been several grounded experiences of setting up village labs, community-based labs, primary healthcare labs. But with growing technology, those are extremely intensive ways of doing things, right? I mean, of really building capacities of lay workers or lay technicians using simple technology, which still remain relevant, but extremely difficult to reach out to larger populations. So with developing diagnostics, their potential to reach out to the cost would probably still remain. For example, from what I understand, the chest X-ray, the portable one is still pretty expensive, and the PCR machines and the kits are still pretty expensive. But they show what is possible, and there's no reason why they should not reach to people we need. And I think we need to do whatever it takes to get there. Different kinds of solutions, and people may have different opinions about different strategies. But there is an imperative that these solutions are rapidly growing. For hundreds of years, there was nothing else except a microscope and the need for a microscopist to do and test acid-fast bacilli, which still remains important. But the fact that it did not and could not reach everywhere, now we have simpler solutions is an amazing one. So we'll get back with more questions, Mikashmi, after Varsha's presentation. Maybe I'll then ask both of you some questions that are common across. And so over to you, Varsha. I think Varsha is probably joining from a mobile because there is a storm and a thunder in Bangalore. Right? That's probably affecting her ability to join from a laptop. So over to you, Varsha, with all the thunder and the storm.
Yeah, I think I'm living up to my name. Apparently, I think my laptop has magically started working again. So let's see if this actually works. Share screen. Here. All right. Slideshow. So this is actually, let me get rid of this. So this is actually, so some of you might have actually seen this painting before. This is, I think, the ideal version of a doctor. There's a sick child, there's a very grave and intent looking man staring, really keeping a vigil in some ways. And so while we stare at this, I would like you to go to this Menti, and there's a little question over there for you, and then we'll see. This is the first time I'm using a Menti. I'm terribly technologically challenged, so we'll see if it works. If it doesn't, no worries. Let me just tell you a little bit about me. I started, as Pavitra said, my life as a diagnostic innovator. And one particular story really kind of changed the way I look at diagnostics. Coming from a very biomedical heavy background, to me, a diagnostic test meant something that could be run in a lab. I didn't really think too much about how that sample would reach the lab or what would happen after it left the lab. And then I got a call from a pregnant lady in Koppal. So Bangalore is down here, and Koppal is about, as you can see from the map, 500 kilometers or so away. And her husband said, since she's HIV positive, she's losing weight, even though she's been on ART, we're a little worried. Our ART counselor says she needs to have this HIV drug resistance test and that you provide this at a cheaper rate. Can we please, can you come to Koppal and take her blood? And I was like, well, no, I can't come to Koppal. Can you come to Bangalore? And he was like, no, we can't do that either. And this was like this utter dilemma. How do you get this lady's blood in a temperature and time sensitive way to Bangalore so that I could do this test, which I have amazingly developed, but I'm not able to reach it to the people who need it. And then this was like, I felt like such a fool. I was like, here I am doing all these nice molecular tests, don't know how to get a blood sample to my lab. And that was sort of the beginning of a journey that kind of took me out from the lab and said, okay, can we also think about diagnostic innovations that actually solve a person's problem rather than solving, a molecular diagnostics problem alone. So it moved me from a technique to a human, really. Anyway, the innovation we created over here was a dried blood spot. So somebody can actually, collect their blood, it gets dried up, you send it by post. And this is now, we shared this know how with another company which had the mindset for scale and manufacturing. And I got touted as some 75th biotech women entrepreneur on the 75th Independence Day of India. So I was very happy about that. But while that was nice, I also realized that it was so difficult to actually solve these other problems. Molecular biologists, and I think people who have trained in technology, we tend to think in very focused ways. And it takes a while for us to kind of come out of this. I'm not going to go into this meandering journey of my company. But this is basically the main question that drives me and my team. In a fragmented healthcare system, how do you ensure access to all for the right type of diagnostic at the right time and at the right cost? And this particular little, golu golu diagram is, it may be a little hard for you to see, but it is actually it transformed me when I saw it. So Vijay Sri Yellappa is a very famous TB researcher, and she basically talked about, she tracked the pathways that TB patients take to be able to get to medication. And there were just so many points over here at which they were just, there's so many options for opting out, where you're just like, you know what, the emotional, the financial, and the physical burden to get a test and then follow that up with a treatment is so immense that it's just better to just kind of, forget about it. So the objectives for my talk, I would hope that you appreciate that diagnostics as a process and not just a test. Recognize the need for the right type of diagnostics test at the right setting. We talk about primary care as a almost like a homogeneous kind of a thing. We say primary care, but primary care in Bangalore is very different from primary care in Udaipur, which is different from primary care in, say, Manpur or any of the clinics that so many of the practitioners who've joined here work at. And I do want to kind of talk about the transformative role of registries in quality monitoring, continuous quality improvement, and promoting learning systems. I'm going to go back to Mikashmi's. Are you guys able to hear me? Because I'm no longer able to see if I'm still
Can hear you.
connected.
Yes, we can
Yeah,
hear
it's
you.
working still. Yay. All right. So this is Mikashmi's paper again. And this has been such a huge um, inspiring paper really to read and to get information from. And again, as she said, lack of access to diagnostics is the largest gap in the care cascade. And another paper talked about how much do people actually pay to access diagnostics, and it contributes to about 10% of out-of-pocket expenditure in India. And this was a very large study done, about 47,000 people in various parts of India. But as you can see, mostly rural, mostly marginalized communities. Um, so I'm going to give you a little quiz. Let's say, you have a patient whom you've known for 1 year. The patient looks thin. He has a towel around his mouth, and he walks very slowly. He speaks with difficulty. You take his vitals. You basically check his temperature, his pulse rate, his, SpO2, oxygen saturation. Let me ask you, how many tests did you perform in this 5 minute or 7 minute period that you must have had with this guy? And while you stare at that, come back and think about this again. All right. Did everybody get the QR code or this thing? Just mindful of the time. Okay, I'll wait for another 10 seconds. Okay, I'm hoping that you guys did something. And let's see if I can pull up the thing on my Menti. Can I ask though, just a show of hands, how many of you thought this guy did 3 diagnostic tests? Just put like a little thumbs up or something. All right. How many of you thought they did 4 or 5? How many of you thought there were more than 6 done? Since people are not really responding on WhatsApp, I hope somebody is responding on Menti. But let's move on. I'm assuming at some point of time you guys will respond. So the actual answer to this, when you think about it, is quite a few actually. Because just by observation, you know the person looks thin. They have a towel around their mouth. They're walking slowly. That itself gives you some clues, right? That's a diagnostic test. You're listening to his story, so that's a clue. So listening is a diagnostic test. The 3 or 4 tests that you do, temperature, PR, SpO2, sure, those are all standard tests. And what is another test? This is a patient whom you've known for a year. You already know this person. Time is a diagnostic test because you know that what you're seeing now is probably abnormal, or maybe it's normal, but you have seen some degree of change, right? So this is diagnostic tests really are a range of things that just go beyond devices and consumables and things like that. So people might wonder, what is this time as a diagnostic test? Basically, the more number of clinical encounters you have, it doesn't matter how long your clinical encounter is. And this is something that we hear over and over again. Oh, clinical encounters, they ideally should be 15 to 20 minutes. That's almost impossible in a real life scenario, right? When you have a lot of these things. What tends to happen actually are micro encounters lasting maybe a few seconds to a few minutes. But you have this sort of repetitive encounter, which is enough to provide a clinician a decent sense as to what's going on. So, time, in fact, is actually a very good diagnostic test. And this is actually very, very relevant in primary care because primary care is supposed to be continuity based, it's supposed to be relationship based. So, when you actually require a diagnostic test, I think it's when your consequences of not knowing can have catastrophic consequences. For example, in the case of TB, you have treatment, and if you don't start your treatment, you are going to die. So the consequences of not knowing are actually catastrophic, not just for the person, but for their families, for their communities. And when the consequences of knowing are overwhelmingly positive, when a pregnant woman is having bleeding, to have access to a USG or a Doppler to say, yeah, baby's heartbeat is fine, baby is doing fine, the consequences of knowing are overwhelmingly positive. And what are the diagnostic tests needed in primary care? As I said, primary care is heterogeneous and undifferentiated. So it's like a tangled sort of mess. And the clinician probably, whether it's a nurse or a doctor, whoever it is, probably have a few minutes, few seconds to minutes to untangle this very naughty thing and to figure out what is a differential over here. And complicating this very complicated fact already, this very complex solution, is the fact that diagnostic devices and kits don't actually take into account this heterogeneity and are frequently unreliable in many settings. Most people, at least, and this is obviously biased, from my understanding of the biotech startup world, of which I'm also part of over here, most labs that are innovation labs have beautiful temperatures, right? They're like in temperature controlled. You're at 26, 27 degrees, and maybe your test works beautifully there. It may not work in 40 degrees or 42 degrees in summer in many parts of the country. So what tests does a primary care clinician need? How do they make the choice of tests and devices? And this was the main question that Pavitra, RK, another colleague, Vasudha, and I asked. And we used the WHO and ICMR essential diagnostics list, which Mikashmi just spoke about, as our guide. We said, okay, what does the WHO say? What does the ICMR say in terms of primary or sub-primary care? Um, so we basically said you have these lists which are very useful, but there's still limited guidance to the provider for choosing and deploying the most appropriate diagnostics. And so we wanted to identify the tests that were required. We wanted to review the availability, reliability, and ease of use, and to study the challenges. And to do this, we interviewed 12 primary care physicians across the country with diverse practices. And this is basically where the practice locations were. Basically all were MD level doctors. So this was a limitation. We did not ask technicians or nurses. These are the 5 or 6 specialties that they came from. The practice contexts were different. 6 of them were NGOs, one was in private practice, one was a government hospital. The rural urban divide was mostly 50-50, and the gender male female divide was also 50-50. Years in practice ranged from 3, somebody who had just sort of finished and they had started their own practice, to greater than 20. About nearly all practitioners chose these particular tests as something that they thought was essential in every primary care setting, regardless of urban, rural, regardless of what kind of background they came from. The ones in italics, blood glucose and pulse oximetry, were basically selected by everyone. And the rest of them, which are not in italics, over 80% of practitioners selected. One thing I want to point out, and Mikashmi had pointed out about mental health as being sort of the upcoming one of the uh, trends in diseases, right? And all of them said that we need mental health indicators or diagnostics. But the current diagnostics that are used, which are PHQ-9 or PHQ-2, are not appropriate for the Indian setting at all. And so they said, yes, we absolutely require a way to screen for mental health, but the tools that we have right now, which are WHO approved or used as standard tools, do not work for us. And so this is something that actually, I personally would like to know, what do people use then? Some of these tests were identified by a fraction or a subset of the practitioners. And for example, if you have a panel like a renal function test, many people said, you know what, out of the renal function test, which is actually quite expensive, if we have serum creatinine specifically as as something that we can do at point of care, that would actually be really important for us. Similarly, in the liver function test, they said it's SGPT, TSH for the thyroid panel, and TrueNAT, CBNAT, or culture for TB diagnostics. There were also very specific tests that were identified as per the context. For example, sickle cell anemia, not everyone said it. People in Jharkhand said, yeah, or Chhattisgarh, yeah, they were like, yes, we absolutely require it. Many others said it's not really relevant to us. Similarly, RA, rheumatoid arthritis, and others sort of these things. What we basically find is that generic lists of tests that need to be available at various levels of the health system do not take into account local context, do not take into account the availability of skilled technicians. If you need a technician to be able to, say, make a slide so that you can use an AI or some kind of a tele microscopy based solution, you're sort of assuming that there's going to be a technician all the time to be able to make those slides, right? And that's not necessarily true. And ease of integration of the tests into existing clinical workflows. When you have a clinic which sees like 100, 150 patients on a day, to say now for this specific test, I need to have a separate workflow. Now you're going to have to change the existing workflow so that patients are now channelized over here. The non-adoption of that technology is going to be pretty high. People are going to abandon that really fast, no matter how interesting it is or how useful it is, because it's just difficult. So it has to be able to ease into an existing clinical workflow. They also do not provide guidance on reliable ways to conduct a test. You say, yes, I need an RBS, but what are acceptable methods of doing it? Supposing I don't have a beautiful little glucometer, is there some other way I can do it? What kind of calibrations do my machines have to have? How do I ensure quality? If I draw the blood now and I do the test 10 minutes later, is that still okay? What if I do the test 2 hours later in summer? Is that still okay? So none of these guidances are there. And so even though you may have a tool or you may have a beautifully functioning device, the result that it spits out may not really be appropriate or correct, and may actually end up yielding very different types of outcomes than what you hope will happen. Many practitioners whom we interviewed had dismal experiences with POC devices. There were design flaws, they were unable to measure extremes, for example, HB less than 4, HbA1c less than 12. Cost, because each of these consumables cost some amount, and so outsourcing actually ended up being cheaper for many people. And of course, they assume availability or training of staff. We realized, as I said before, there's innovations also required in specimen collection, storage, and transportation, which is one of the reasons why the tongue swab for TB is such a promising thing. And I think there's so much of excitement about it. And very little information exists on critical test parameters for POC devices. We don't know, for example, if you look at a hemoglobinometer or a glucometer, we don't know what the sensitivity is. We don't know what the lower limit of detection is. And practitioners rely on Google reviews, word of mouth, trial and error to select devices for their practice settings. So this is something that we realized. If you're in an urban context, tier one city, the suggestions for investment in diagnostics is actually don't invest in point of care diagnostics, outsource, because there's such an oversaturation of laboratories in tier 1 cities or even tier 2 cities these days, that it's far better to actually exploit various existing methods of transport to ensure timely collection and storage and transportation. What you have to invest in is actually time to create these systems to track quality. What is your turnaround time? How long are you keeping the sample stored before you actually test it? And you also have to negotiate with your provider to say, listen, I don't want you to come just once a day. Come twice a day, come 3 times a day, but pick up my sample as quickly as you can. And you can do that because a market allows it in many urban cities. If you're a rural primary care clinic, which is either standalone or attached to a hospital, we would suggest that you invest in some point of care devices. I've listed them out over here. But you consider also investing in a lot of small in-house biochemistry, hematology, etc., both to build local capacity as well as parallel revenue sources. People are willing to pay to get a laboratory test. It doesn't have to be humongous amounts, but if you have a few machines where you can actually allow these kinds of tests to happen, you are providing both a very necessary service and you're helping yourself build a revenue source. You should outsource the rest. If you have a network of rural primary care services, yes, again, invest in some devices. Check relevance of certain other devices such as HbA1c, lipid profile, spirometer, retinometer, HPV screening. These are all things, again, that are relevant to your context of practice. Um, and of course, the cost of the consumables. If, for example, HbA1c, we realize that while there do exist very nice point of care devices, the chip costs about 500 rupees, whereas if I outsource it, it costs me 400. So why would I actually waste my money on my chip, especially when the HbA1c I only outsource it maybe 4 or 5 times a week? It makes no sense for me to do that. And if there are telemedicine-based primary healthcare clinics, as there are coming up, so many of them are coming up right now, we would suggest to invest in robust, easy-to-use point-of-care technologies that can be done on camera to ensure consistent quality. Because if you have a bunch of remote clinics and somebody whom you're not familiar with is conducting these tests, you need to ensure that quality, the correct way of doing these tests is actually being followed every single time. And in all these cases, I would say that investment in time in communicating with innovators is actually really critical. So if you have a facility which can become a beta testing site, there's actually of great value not just to you, but also to them and to the entire ecosystem. I want to talk a little bit about data registries before we end. Because basically, yeah, do we
Yeah,
have
sorry,
time?
Varsha. I think we'll probably have to be quick
Stop here.
because we are
Sure.
almost.
I can just do it in 1 minute. So basically, I want to talk to you about this data registry from our own practice. All it does is tell you about the name, age, etc., and then you can see the entire thing, the clinical conditions along with the result and the outcome. Same thing with the rural physiotherapy program. And these registries have been incredible in driving lots of learning, not just at a higher level, but also at the ground level. All our technicians are actually excited about looking at these to be able to see, okay, what is actually happening? And this gives you lots of ideas to improve and to figure out where your errors might be happening. Is it an error in the lab, or is it an error in the collection of samples, and so on and so forth? And in summary, this is all I've talked about. I've hoped that you gain a understanding that diagnostics is more than just a device, that different contexts require different tests, and that registries are incredible in transforming quality. That's all. Thank you so much.
Uh, Thank you, Varsha. You can probably stop sharing. So,
Yes.
thanks very much. And I think you brought the focus that diag- what is important is timely diagnosis and ability to diagnose, and not only the availability of diagnostics per se, which is more than just availability of equipment. I think you also highlighted the point that there could be a disconnect between the national kind of diagnostic lists versus area specific, where based on epidemiology, I was surprised to see the TB diagnostics as kind of optional by several in this study. While for us, those who work in areas with high prevalence of TB and lack of access to TB, it would be absolutely number one any day. So how this kind of plays out, I think also highlighted the point that there is absence of guidance on how to, which diagnostic to use, which reagent to use, which will be suitable in a given setting, how to use it, what is their sensitivity, specificity, etc. So maybe I would start asking that question to Mikashmi, that this question that how do you decide? You're sitting in a primary health center or in a group of clinics, or even if you're at a district in an administrative position, how do you decide which diagnostic to use, and what are the considerations? Is there any support system? Are there any, what Varsha, the landscape that she did, found that actually there was very little guidance on any of these issues, and that makes it difficult to decide what to.
Yeah, no, I think that's a great question, and we keep getting this question, what diagnostics should I put? So I think there are a couple of things that definitely people should look at. Sitting in a primary healthcare setting, one is if you have a national essential diagnostics list. I think that's a good starting point. But that may not cover all the problems that you have, or that could be overestimating the diagnostics that you need. And then that is where the disease epidemiology comes into place. The third thing, so one is looking at the benchmark that you have. Second is looking at the disease epidemiology of your own region. And lastly, looking at the essential diagnostics list. Something that every primary healthcare has done is optimize what medicines should I have in my primary healthcare. So if you can treat something at that facility, you should first be able to detect that in order to treat that. And that is where I think we need to triangulate these data points to be understanding what diagnostic should I be putting there. That being said, the vertical programs, although should not be siloed, but something for pregnant women, looking at the population dynamics, the population pyramid as well. If a region, and this is something that was very interesting, I saw in UP, there were some villages that had a lot of young women, pregnant women in that setting, whereas there were some very remote villages that I went to that didn't have that very young population that they were catering to, right? So they didn't need to worry about it. But at least where you're referring to the population pyramid of a particular region, catering to that population itself would be important. You need to have tests that need to be done at an ANC visit. You need to have tests that if there is a neonate coming into your facility, you should be able to detect anything or not. So I think that is where these three different points can triangulate, help answer that.
Right. I'll come back to that because there is one problem. Of course, I think that's very nicely said that if you have drugs for certain conditions and you're treating them, then you need that is one kind of a parameter to decide
Yeah.
which diagnostic. The second question then comes is that amongst the whole range of diagnostics that are available for a specific, for example, hemoglobin, a simplest thing, right? Which one do you use? There are so many in the market. How do you identify which one is the right thing? Unlike the drugs where there is an FDA, I mean, of course, there are diagnostics which are some of which are approved by ICMR and others, but for many there is no kind of reliable, and that too in a primary care setting where temperatures may be different, etc. I mean, hemoglobin, again, coming back to this example of hemoglobinometer where some of them just don't work at 45 degrees. Right? So how do you decide on? So having a guidance on that.
Yeah, no, I think that is a brilliant question because so we are working with ICMR on trying to understand that it's not just the big machines that you need to validate, but there needs to be a mechanism down, a little bit downstream as well. So there needs to be, you can't expect a primary healthcare provider to do these validation studies. Will this work or not in my primary healthcare setting? But that needs to come from more of the government labs or the district labs supporting that these are the options that you have within this glucometer or a hemoglobinometer, and these are the ones that you can procure. So I know that there is a lot of tendering that happens, and usually it's the cheapest that is selected. But that is where we are working a lot with the government, the state governments, but also at ICMR level to kind of come up with these guidelines. At least every state, every region will have a district lab, will have a tertiary care hospital. Can we at least put this responsibility on some of these labs to take up that these are the options? Within these five options, you can pick whichever one suits you best or whichever one you are able to procure. So that is a very good question, and it's still a work in progress, I can say.
Thank you. Uh, Varsha, you talked about the need for innovators and the practitioners to come together. And one is what makes you, I mean, what is the problem that it's likely to solve? And how do you see this unraveling?
Yeah, as I said, I think the some of the ideas that innovators have about what the actual problems may be slightly biased or skewed. This is certainly something that for example, think about the hemoglobinometer. It's expected to be the whoever innovated it is thinking, okay, we assume that most people are going to be in this range. It's sort of in the central limit theorem. It's like, in mostly are going to be perhaps between 5 to like maybe 16. But this thing, they don't get exposed to populations that are like severely anemic. Like I know at BHS you've seen people with HB of 2 and things like that. And so or for that matter, those with lean diabetes who have HbA1cs of like 12 or 13. And I think that's one of the things that innovators perhaps don't typically get exposed to the extremes of parameters because they don't see that. Other thing is also they may not understand clinical workflows or clinical decision makings. You say, I see that there is a need for an X-ray, so I'm going to make a portable X-ray. But then how is this portable X-ray actually going to be integrated into an existing clinical workflow? Where is the space for it? How do you protect other people who are around it? I think those are sort of end to end things which an innovator, when they start talking to practitioners, they'll immediately be able to get that. So I do think that's one of the things that we should start promoting, to say, don't come to a practitioner after your innovation is done and it's already in the market and you've spent crores of rupees getting it through all these regulatory hurdles. Talk to the practitioner right in the beginning. find out what exactly is a true real world sort of situation that you're going to be solving. And then you may not have to waste as much money.
Sure. No, thanks. I think the probably the need is clear that there needs to be probably a dialogue between people who use it and people who develop it, and oftentimes it's inadequate, leading to probably sometimes unrealistic solutions, or and then the problem comes when the rubber hits the road. And feedback. I'll just maybe take a few questions from the audience quickly. One are about the availability of different kinds of POC devices for creatinine, for lipid profile, for LDL cholesterol. I think this itself shows what we are talking of, right? I mean, these are all practitioners who are posting these questions, I assume, and we don't know really which one is available. Is it available or not? If yes, which one to use? So probably, if you want to, either if you want to have a quick response to these different kinds of needs for point of care, are they available or not? If yes, is there a way to, which one should be deployed, etc., or how do you decide? So some quick.
Yeah, sorry, Varsha, do you want to go ahead?
Go ahead, go ahead.
I think I just posted like a link of the paper, and I'm going to post it here as well. So there are actually point of care devices for lipid profiles, for LFTs, KFTs as well. The problem is that not all POC devices that exist have been currently validated by ICMR, and that's like the principle now. You can't have a test unless it's validated. The questions that I'm looking at, I think this is something that needs to be brought up is what is the need? So as you were saying, if the practitioners really feel that this is a POC test that we need, then that is something that probably needs to be communicated back to a level where these can be addressed, whether it's ICMR or the state government, because I know that the technology exists. And I know that these technologies will work in India for sure. The only caveat is there a need? Probably. So it's a very simple example I'm going to give you. The tongue swabs was something that India wasn't sure, not just India, WHO wasn't sure if they want to take it forward for TB or not. But there was a lot of advocacy, there was a lot of community engagement that was done for tongue swabs for TB. And that is where ICMR, then India actually became the first country to even start validating it, even before WHO has reviewed the evidence. They're going to review it in November, but India has already started doing that. So I think that advocacy and the community engagement needs to start happening based on what POC devices would people practitioners benefit from.
Thank you. I think the challenge here lies in a quick validation, review of evidence, and more dialogues between practitioners, policymakers, people who need to validate, and people. I think ultimately the advocacy has to come from people who need to use it, right? I mean, that's where they're the ones who need it. So they should not just wait for something to come their way, probably. There is an interesting question from Dr. Shridhar about that there are also a large number of tests which are not validated, which are not essential, which are, but looks good because, you offer something to the patient, you charge money, everybody's happy that way. So, a need to say that, okay, this setting, these tests are not relevant or a way to, so.
Off the bat, I would say yes, that is important. I think it will, I hope and I think it will happen in the second draft of India NEDL because it happened in the WHO EDL. There is a do not use or a is not recommended section in the WHO EDL. And that is something that definitely should happen. For the India EDLs and the national EDLs or the regional EDLs as well, that you don't need all of these fancy tests all the time. And I keep seeing that happening with my family. They go to a doctor and they add like 15 other tests, and I'm calling them that you don't need all these tests. So I definitely agree, and that's a very good point that was raised by Sharad. Yeah.
Yeah, I
Um,
want to add something over here though. The way the finance models are also based off it, if you were to get, say, an HbA1c alone, that costs more than if you were to get a panel of HbA1c
Mm.
and this and this and this. And so, of course, people are going to be like, yeah, sure, why not do
Let's
everything at
not.
one
yeah.
shot?
Very good point. Yeah.
I do wonder about the
I think
ethics
it,
of it, though. Can you
yeah.
say you can't do a test to someone when they're like, well, I want to do it? And can you actually say, we recommend that you don't do it, but you can't actually stop anyone from doing anything?
But I think one of the non-recommended, what I meant was, so that's a very good angle that you bring, Dr. Varsha. I think so if a patient wants it, it's good to get them done. But then there are some tests. So it was happening a lot back in a couple of years ago, where, for example, for TB, they were giving these serological tests to be able to diagnose an active disease. And that was up until a point that there was a policy that was made. It's a negative recommendation. It should not be done. People
Yeah.
were giving out those tests and charging a lot of money just for that. And I think that's where the evidence piece comes into play, that what test should not be done is important to be mentioned. But I agree with your point. Like, if I say that I would want to get an echo done, there are no clinical symptoms, but I would want to get it done. I think you're right. Like, we can't tell the patient, like, we won't recommend it, but sure, if you want to go get, yeah. Yeah.
There were some questions about legal issues around ultrasonography, particularly. There's also some legal issues around X-ray, but the issue around ultrasonography in India, especially because of the PCPNDT Act, precludes access to something that's so essential in primary health. I mean, it can be transformative for primary health care, but I know that from a technology angle, there are several efforts going on where ultrasonography at the front end will either obfuscate the genitals or will not. The person at the front end won't be able to report. It will be through AI reported at the back end from a certified center. So those efforts are going on, and I think again users need to really, primary healthcare practitioners need to really raise the voice for expediting some development as well as. So since there's very little time, I'll just one very quick 1 minute, and knowing that Mikashmi is an optimist, that's what she started with, to say that what would you like to see in future in a primary healthcare setting from point of view of diagnosing and diagnostics. What would you like to see in a primary healthcare, say 5 years from now? 20 years is too far.
Yeah, no, I think for me, I walk into a clinic, and if I know that whatever condition I'm walking through, one, there is a doctor that is available on site. That's the biggest thing that I saw was not there. There's a doctor on site, and something as simple as a glucometer, as simple as a thermometer, working thermometer, a BP machine, the very basics. My dream would be there is a list. We have these SOPs that are put on these walls, these fancy SOPs. I would want that diagnostic list being put on the wall. Everybody can look at that. Diagnostics is something that is important and critical. And if there is something that is not available, there is a mechanism that is available on site, that people, rather than making people move, their samples can be collected, and a test can be done. Lastly, most importantly, doing a test is not enough. Getting the result back is most important. So I would want, in my dream primary healthcare clinic, every person who walks into a clinic is aware that they know what they are suffering from, and before they get a pill popped into their mouth, they know why they're taking that pill and what do they need to do. So that's some sort of a optimistic dream that I have.
Varsha, I'll ask you a reverse question. I think you work probably closer to the ground, but I'll ask you more of a that how do you see in future that that how this validation, development, and deployment of diagnostic, how do you see that happening in future in the most optimistic sense?
Yeah, I think I do. I have mentioned this in my talk as well, that if there were more communication, basically, or if there are more platforms where rural clinics
What's
or
your dream?
yeah, I think I would like to see these sort of diagnostic innovation platforms kind of come up, where there is this sort of constant um, trying out of this thing. And I mean, I understand not everybody can do it, and then it's also a matter of like resources and mindset. And I think that those mindsets should be cultivated. If there's a fellowship program for innovators to kind of be immersed in primary care settings, for instance, things like that. I think that those would be things. More than anything else, I would like to kind of underscore that, when we think about the WHO building blocks for health systems, we're like, we put in all these Lego bricks and magic happens. And I think that is very clear that magic doesn't happen. It's a much deeper thing about curiosity, culture, and a desire for outcomes rather than just saying that something is present or not present. Referrals, as Mikashmi just pointed out. So I do think the culture has to change to saying our targets should be patient outcomes and not the number of things that we have. So those would be the things that I would put in.
Excellent. I think that's a good dream to end with, where a person who needs the care receives it with compassion, with empathy, with responsiveness at an affordable cost. Now, whether it's and diagnostics as a significant piece within it, which is available to everyone who needs it and is not available to one who doesn't need it. So I would not try to even summarize the discussion. We can do that probably, as an afterthought, because there's so much to kind of chew on and understand and synthesize. But I would request Prakash to kind of thanks everyone and have the last word. He always has the last word. So the third PhD in the panel.
Thanks, Pavitra. So thank you everyone for a wonderful conversation today evening. Dr. Mikashmi Kohli, it was wonderful to hear the landscaping work that you had done and what is coming out of it, right? And I think it's very important, as you rightly said, to maintain that optimism, because with all of what is going on, I think it's your perspective on how things can actually happen, I think was an important takeaway. Thank you so much for joining us today and presenting that. Dr. Varsha Shridhar, so it's wonderful to see the work that you've done. Thanks for sharing that. Also, all of those anecdotes and those those small bit conversations which actually made it much more experiential for us today in the during the webinar, right? For those brief periods of time, we were transported along with you to all of those rural places, right? So thank you so much for making it so interactive. And thank you so much, Pavitra, for co-moderating this and shaping the conversation today. And finally, my thanks to all the participants who have joined today to be part of this webinar. As always, it's a pleasure to have you, and we hope to have you join us in the future episodes of these dialogue series. Thank you again, and have a wonderful evening.
Thanks, everyone.
Bye-bye.
Bye-bye.
Hello.